Hello, good morning. I'm Ashok Kurokade, consultant rhinologist and anterior skull base surgeon from Winchester and the University Hospital, Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior Skull Base Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Hello, Sagu.
The
Can
video
I invite Kwame to introduce Raewyn?
Hello, can you hear me, Ashok?
Yes, please.
Welcome, delegates, and thank you for your very kind invite, Ashok. As I say, myself and Andrea Burgess, my colleague, will be hosting this quite interesting session. I'd like to take the opportunity to welcome Raewyn Campbell. She needs no introduction, really. I've not been fortunate to meet, but looking through, it's such a glowing resume that she comes with. Raewyn is an associate professor and holds experience in both rhinological and skull base surgery, and has a number of fellowships to attest for this. She's taken essentially 2 rhinology fellowships, one in Auckland, New Zealand, the other in the States, and her skull base fellowship was also conducted in Ohio in the States. She's certainly has an international prowess running conferences, courses. And she has over 40 journal articles and book publications, presents at specialist conferences all around the world. So I'm very honored to introduce her as our speaker for pediatric functional endoscopic sinus surgery. Welcome, Raewyn.
Thank you very much. I'll share my screen now. That was a very kind introduction, Kwame, and also thank you to Ashok for the invitation. I'm thrilled to be here. Can you all see my screen before I go ahead?
Yes, we can see your screen. Thank you.
Perfect. Right, so I'm going to now talk about pediatric nasal surgery. One of my appointments in Australia is at one of our largest children's hospitals. And so these are my disclosures. I really love this quote, that adults have more face. If someone could mute their microphone, there's a lot of background noise. So this quote, that adults have more face and less brains, and children have more brains and less face. And I love this quote because it really highlights that difference in craniofacial maturity between adults and children. In particular, children have a larger nasolabial angle, shorter nasal dorsum, their tip is less projected. They have a flatter tip with a shorter columella, more rounded nares, and their septum has a higher cartilage to bone ratio. And when we're looking at nasal development, there are essentially two growth periods for children. The first 2 years of life, and then around the time of puberty. And it ends a little bit earlier in girls than it does in boys. Now, children have quite a few respiratory tract infections. About 10% of those, 6 to 8 per year, are complicated by rhinosinusitis. Typically, it occurs more in children who attend daycare, particularly with more than 5 unrelated children. Now, if we look at the prevalence of rhinosinusitis in children, it's actually not as low as we think. In fact, if you look at the data, it's in some ways more common than it is in adults. The difficulty is children often don't complain or they don't know any different. Now, in an adult with chronic rhinosinusitis, the most common symptoms are the typical hyposmia, anosmia, postnasal drip, nasal obstruction, and rhinorrhea. But in children, they're more likely to have a cough than they would hyposmia. Typically, it presents at night and it can be productive, and it may be followed by vomiting. They also have a very common symptom of rhinorrhea. The quality of life in children with chronic rhinosinusitis is quite affected by it. There's a lot of missed school, impaired concentration, poor sleep quality, and impaired emotional health. And if you look at body pain and physical limitations in these children, it's actually worse in children with asthma, ADHD, juvenile rheumatoid arthritis, and epilepsy. So it's not something to be underestimated. Children with chronic rhinosinusitis have a strong family history of allergic rhinitis, and a lot of them actually have allergic rhinitis. They're more likely to have more exacerbations of their asthma and have a higher exposure to tobacco. But they tend to have a more neutrophilic disease than eosinophilic. In fact, an eosinophilic disease is rare in children. So one of the main concerns in pediatric nasal surgery is what impact are we going to have on the growth of their midface if we operate? What I really think we need to change the way we look at this and have a look at what the impact of prolonged nasal obstruction has on the growth of the midface in children. So let's look at nasal growth. The adolescent growth spurt tends to be around 8 to 12, and then it descends, and in girls it's a complete around 16 to 20, boys up to 25 years of age. Now, if we look at the septum, it's 7 bones and 1 cartilage. Each bone has 1 to 2 ossification centers. Now, because it's a midline structure, it's encased in and surrounded by multiple facial bones. Therefore, it can be impacted on and have an impact by its surroundings. Now, the dorsal septal cartilage is the main supporting structure of the nose. It's a facial growth center. So any cartilage loss, particularly in this area, can affect the growth of the orbits, nose, and the maxilla. And this is a child who had an unmanaged septal hematoma. Now, if we have a look at nasal septal deviation, it's very common in children. Birth is a traumatic experience. They break their septum a lot, especially because they've got big heads and they're clumsy. But the importance is the age at which the injury occurs, how much injury has occurred, and also the age at which it occurs, particularly before the age of 3, is very important. but the septum continues to grow up until about the age of 20. So is a blocked nose a problem in children? Well, let's have a look at the impact of nasal obstruction on the lower airways. So most of our respiration is via the nose at rest and during exercise. In fact, only about 10% of our breathing is through our mouth. But if you've got a bent septum, those numbers change and we spend more and more of our respiration breathing through our mouth. Now, is that a problem? Well, yes, it is, because it's inefficient. Our upper airway resistance is 2.5 times higher with mouth breathing than it is with nose breathing. So if we look at the difference between the upper airway with children and adults. So first of all, in adults, we've got a higher distance between the maxilla and the nasal bone. The angle between the angle of the mandible, the jaw and the chin is greater in adults. In a child, the hyoid bone is tucked underneath the tongue there, but in an adult it's descended and is more exposed and therefore less stable. And an adult has a longer pharynx and a greater tongue height. So children have a more oblique orientation of the pharynx compared to adults as well. And essentially what this means is the mechanical arrangement of the tongue and the velopharynx in adults is unstable. And therefore an adult who has obstructive sleep apnea, they can have this regardless of whether their nose is blocked. And we all know that if you unblock the nose of someone in OSA, it has minimal impact in an adult with the OSA. But in children, it's different. This arrangement is stable. Therefore, if you've got a child with sleep disordered breathing and a blocked nose, if you can unblock their nose, you can actually have a significant impact on their sleep disordered breathing, and it can cause it to vanish. So nasal patency is crucial for children with OSA or any sleep disordered breathing. Now, if we look at this study on pediatric nasal obstruction, when they looked at 98 children with a bent septum compared to controls, it had a huge impact on their craniofacial development. But why is the nose important? Well, nasal obstruction can also lead to significant pulmonary arterial pressure problems. And also these studies looking in rabbits where they had prolonged nasal obstruction, it actually led, if you block one nostril, it led to that chest, the ipsilateral chest wall to develop abnormally. These Rhesus monkey studies where they blocked the monkeys' noses for the first 6 months of their life led to huge cephalometric abnormalities in those monkeys. If you block the nostril in a healthy control, the contralateral lung hyperexpands to compensate. Also, if you blow air into one nostril of someone, again, a healthy control, that ipsilateral lung expands. And when you anesthetize that nasal mucosa, this effect disappears. If you blow air into the nostril of someone with a laryngectomy, again, that ipsilateral lung hyperinflates. Now, this is all due to the nasoventilatory reflex, which is a communication between V2 and the vagus. There's also a trigeminal hypoglossal reflex, where there's again a communication between V2 and the genioglossus, which then results in a greater tone in the tongue muscle. So if we don't have nasal airflow, that has a huge impact on the growth of our facial skeleton. Yet continuous nasal airflow provides a stimulus for lateral growth of the maxilla and lowering the palatal vault. So nasal obstruction actually alters orofacial muscle activity. Now this causes, if you've got an imbalance of the tongue and facial musculature and soft tissue, and this is what is actually got a name, it's called Moss's functional matrix. And you can see this in children who've got myotonic dystrophy, Ehlers-Danlos, etc., such as this child, where they've got that musculofacial problem with their tone and leads to the significant impact on their facial growth. Also, if you're a chronic mouth breather, you adopt a compensatory posture to allow for the reduced nasal airflow. It drops the position of your mandible, it makes your tongue come more anterior and inferior, and it reduces the tone of your orofacial muscles. Also, there's a lot of cardiovascular impacts of prolonged nasal obstruction. Now, if you look at these impact on adult growth, you can see that this was a study looking at adults with nasal septal deviation. And there was a strong relationship between the deviated septum and the facial asymmetry. And this is a patient of mine where you can see the same thing. This is a young boy who had a deviated septum that wasn't managed. And these photos are 9 years apart. You can see that impact on his facial growth and facial symmetry. So how do we avoid our children growing up to develop faces like this? Is there a reason? Should we not operate on their noses, or should we actually consider it? Well, let's have a look at this study. This was looking at pediatric septoplasty. They had a retrospective controlled study looking at 44 children where they did septoplasties via a hemitransfixion incision. They followed them up for quite some time, and really what they found was the only difference in the nasolabial angle in girls. And when they did a sub-analysis, it was only those who had the extracorporeal septoplasty. Any other septoplasty technique had no impact on facial growth. And that's because you have these two septal growth zones, the sphenodorsal zone up the top and the sphenospinal zone down the bottom. These two zones are what contribute to the growth of the premaxilla and maxilla and the length of the nasal dorsum. In children, if you can avoid interfering with these zones, you are safe. So with a septoplasty in a child, the advice is to leave the mucoperichondrium intact. Don't do a drainage hole and avoid tearing it. But it's safe to elevate the mucoperichondrium unilaterally or bilaterally. Reconstitute the areas of contact between the septum, vomer, and the perpendicular plate of the ethmoid, and reposition any remodeled cartilage. Avoid the septospinal ligament, which is what anchors the septum to the maxilla and premaxilla, because that plays a role in the forward growth of the maxilla. And also avoid separating the cartilage from the perpendicular plate superiorly or dorsally, because that is what impacts the length and height of the septum and the dorsum. Now let's look at the impact of adenoids. Adenoids grow up until about the age of 5 or 7, and then they slowly start to atrophy. But they have a big role in sinus disease because they're a bottleneck. They also serve as a bacterial reservoir, and the bacteria in the adenoids have been noted to be identical to the bacteria in the sinuses of children with CRS. This was a study looking at adenoid tissue specimens and children with rhinosinusitis and OME, and there was all of them had positive cultures with typical bugs for CRS. And this was another study looking at the microbiology of the adenoid core specimens and comparing it to middle meatal swabs, and there was a huge correlation. Also, if you look at biofilms in children with CRS or children having an adenoidectomy for sleep apnea, the CRS patients have a huge biofilm load in the adenoids, yet not in the children with sleep apnea. Again, the bacterial isolation rate isn't related to size, it's related to severity of rhinosinusitis in adenoids of children with CRS. If you do an adenoidectomy in a child with CRS, their quality of life improves, as well as the symptoms of their CRS improve as well. Now, this was a study looking at, we all know about adenoid hypertrophy and facial morphology. We've all heard of the term adenoid facies. But I particularly wanted to draw attention to this study where they looked at a huge number of children who had adenoid hypertrophy, and they measured the cephalometric measures. What they found was the more severe the airway obstruction led to the more divergent cephalometric measures. But what they noted that was tend to be more significant before and after the age of 6. And so their recommendation was if you can unblock the nose of a child before the age of 6, you're going to have the greatest impact on their craniofacial growth. Now, if we look at the inferior turbinates, the inferior turbinate develops on the lateral nasal wall, yet the middle and superior turbinate actually develop from the roof of the nasal cavity and the septal wall. The inferior turbinate develops from the maxilla and the lateral cartilaginous capsule, yet the middle and superior turbinate actually develop from the ethmoid bone. The inferior turbinate has its own ossification center. It ossifies in the 5th embryonic month, and therefore by the time a child is born, the inferior turbinate is fully ossified. So surgery technically is not going to impact on the development of any other facial bones. We also know that to have greater impact and long-term success rates, you actually have to remove the erectile tissue, also the bony tissue in inferior turbinate surgery to get the best results. So is it safe to operate on pediatric turbinates? Well, this study was looking at turbinectomies in children, not a turbinate reduction, but turbinectomies. They looked at 227 children who had turbinectomies done for nasal obstruction and rhinorrhea. They followed them up for 14 years. It was a great success rate, but the key thing is The ones that failed were the ones that didn't have complete removal of the inferior turbinate, particularly the bony tissue. There was no impairment on their facial growth and no evidence of atrophic rhinitis. Now, if we look at the impact of the adenoids and inferior turbinates and the relationship between the two. So this study, what it did, it was a prospective study looking at children with adenoid, looking at inferior turbinates and adenoid size. And what they found was if you had large adenoids, that tended to be associated with smaller turbinates and a lack of atopy. However, if you had large turbinates, they tended to have smaller adenoids and more likely were to be atopic. And their hypothesis was that if you had a locked nose anteriorly, it was more protective against adenoid hypertrophy. This is a prospective case series looking at the impact of children with allergic rhinitis and sleep apnea. And what they found was that if you address the turbinates as well as the tonsils and adenoids, you had a much better outcome compared to just doing an adenotonsillectomy alone on multiple measures. Also, if children with chronic rhinosinusitis who have endoscopic sinus surgery do much better than children who are just managed medically. So with pediatric sinus surgery, it's safe with good outcomes, low complication rates, and it does not compromise midfacial growth. In fact, you have more likely to have adverse outcomes if there's a delay in surgery in these children. Don't forget to consider in children with chronic rhinosinusitis, atopy, immunodeficiencies, and undiagnosed cystic fibrosis or primary ciliary dyskinesia. Now, I get a lot of questions from the parents of the children I treat about CT scans. Now, there are theories that children are at greater risk of developing cancer from radiation exposure, and there's theories behind this, that they've got more rapidly dividing and growing cells and therefore they're at risk of damage from the ionizing radiation. Maybe they're more sensitive to it. Or that they've got a longer life ahead of them, therefore a longer chance to develop a cancer. Or finally, that the radiology departments actually don't adjust their radiation dose down for children when they're scanning them. Now, this all came out of the studies, two studies that were published, one looking at children who are having annual Panorex x-rays under the age of 10 or having x-rays when they were very young. And they found that they were nearly 5 times more likely to develop a meningioma. And in the same year, this study published showing that children that had more than 30 milligray of radiation had a relative risk of developing leukemia of 3.18 or 2.82 of developing a brain cancer with more than 50 milligray. But let's look at the lifetime recommended dose of radiation is about 100 millisieverts. If we look at a CT of the sinuses, this is a stock standard sinus, it's 0.7 millisieverts. But a cone beam CT is 0.27 millisieverts. Now, if we look at this to put it into context, the natural background radiation that we're all exposed to in a typical year is 3.1 millisieverts. So it's actually quite low. Now, if we look at our in-office scanners, you can see some of these Zorin in-office scanners, it gets down to less than 0.1 of a millisievert for a CT scan of the sinuses. Now, this, hopefully you can all see this video. This is a child, 11-year-old girl who came to me with woke syndrome, or she had hypertelorism, blocked nose, rhinorrhea, hyposmia, etc., etc. And when I examined her in the nasal cavity, there were polyps everywhere. And I wanted to do a CT scan, but her parents were quite concerned about doing a CT scan. So what I did is in my office, I pulled up the radiation risk calculator, and this is the link if you'd like to, if you download it yourself. And I put in her details. So she's an 11-year-old girl, and I did it as a standard CT, not one that adjusted down for radiation dose. And the increased or additional risk of cancer from one CT of the sinuses for this girl was 0.017819%. So the parents were much more reassured by this, and as you can see, we went ahead with the CT. So for children having imaging, you want to ensure that your radiology department adjusts the scanner for children, as many don't, and they adjust it to a level that is as low as is reasonably achievable. Also, I get asked about general anesthetics in children, and this is because often when you operate on children, you have to do a general anesthetic to debride them. They won't allow you to do that in the office. Now, the concern came out of animal studies where they demonstrated that general anaesthetic at critical developmental time points led to some structural, functional, behavioural deficits. Now, this study that was put out a few years ago now looked at quite a large number of children who were exposed to anaesthetics under the age of 4, and they did find that there was a very subtle difference in their school grades and their OQ scores. And it was detained to be the same depending on whether they had one or multiple exposures to anaesthetic. But really the key time period they found was actually only between this age of 37 to 48 months. And the difference from the anaesthetic was actually less than the impact on their development of gender, maternal education level, or their month of birth. More recently, this study came out, this is an English study that came out looking at anaesthetics before the age of 4, and they looked at a whole bunch of developmental measures. And they found that there was no impact on global neurodevelopment, but there were some subtle differences on dynamic balance, and that was only on the multiple anaesthetic group, manual dexterity, and social communication. And I also encourage a lot of my parents who ask about the impact of an anaesthetic on their child to go to this website called Smart Tots, which has a lot of information and resources for parents and family, and it can really be quite reassuring, but there's also a lot of resources for medical professionals as well. Now, a lot of my children irrigate, and they're very good at doing it. This child has given me permission to share this video of her irrigating, and I show this to the children I operate on to say, look, this is how easy it is. Often I'll give them, this is an adult bottle, but I'll give them a pediatric bottle. And and before the surgery, I get the parents to get the child to play with it in the bath and squirt their younger brother or sister and demystify the irrigation bottle to the children. So by the time it comes to their surgery, they're pretty familiar with it. And I've actually found that I very rarely have a child that won't use it. Now, but while I'd like to finish with this child, hopefully you can hear her breathing. So this is a young girl with cystic fibrosis, with severe sleep apnea. Her mother was barely getting any sleep because this is what her sleeping was like. She was hypertelluric. It's difficult to see on those videos, but she's quite hypertelluric. And this is her CT scan of the sinuses she has developed. She's essentially got pan sinus disease, and she was actually referred to a colleague for an adenoidectomy. And she did actually have big adenoids as well, but really, essentially, that was the least of her problems. And so I took this young girl to theatre. This is me just injecting. But for the sake of time, I won't dwell. But I did do a septoplasty on this child. And I did bilateral and modified medial maxillectomy. As you can see here, just how boggy the lateral nasal wall is with all of her sinus disease. And I opened up all of her sinuses. That's the septoplasty. I'll move along. This is all the pus coming out after I decongested her, the pus coming out of the ethmoids in the middle meatus. And I'll move on a bit through here. This is in the maxillary sinus. Before I did that, I just opened it up and it's completely opacified. It was mostly actually staph in this 3-year-old. And then you can see now the thick mucus in the ethmoid sinus on this left-hand side here. And I'll move forward. That's it coming out again of the ethmoid sinus. And I'll move forward a little bit further. And you'll be able to see in a moment, this is me blotting the eye, and that's coming out of that abscess that she had up, which I then went on to open up. And this is her, hopefully you can hear this, this is her week post-op. So in summary, the inferior turbinate has its own ossification center. Chronic nasal obstruction impacts facial growth, and nasal obstruction should be treated. Pediatric turbinate, sinus and septal surgery has no impact on facial growth as long as you're mindful of those areas of the septum. And with inferior turbinates, just addressing the soft tissue part of it is not going to have as great an impact is if you actually address the erectile tissue and the bony portion of the turbinate. We want to achieve airway patency under the age of 6 if we can, to have greatest impact on their craniofacial growth. Don't forget to assess the adenoids in a child with chronic rhinosinusitis. And in a child with allergic rhinitis and sleep apnea, don't forget to address the turbinates as well as their tonsils and adenoids. That'll have the greatest improvement. And don't forget to assess your radiology settings with your radiology partner for CT scanning in children. And thank you very much.
Thank you. That was an absolutely fantastic run through of the entire components of paediatric sinus surgery and disease. We have one question just regarding what would you consider the minimum age for paediatric septoplasty, given those impacts on growth?
So as you want to do it before the age of 6. That young girl that I did the septoplasty on, she was 3. But I needed to do that septoplasty to actually get access to the ethmoid abscesses that she had on both sides. That's the youngest I've done a septoplasty on. I've had a 4-year-old who's secondary to trauma. His septum was obstructing his nasal cavity on one side, and I did a septoplasty on him to unblock his nose.
Okay.
But yeah.
So, I mean, I would really like to take this opportunity to pick your brains, because there's a huge amount of discussion within the paediatric areas regarding how aggressive we should be with the nose, and really how aggressive should we be treating nasal obstruction, even in terms of the adenoids. We'll often accept a snotty child aged 2 or 3, but really, are we doing them a disservice in terms of the impact on their growth and also that bacterial reservoir on their immune function, basically?
Yeah, absolutely. We are doing them a disservice by not addressing that in whichever way you decide to do it. Because if you leave them, first of all, they're suffering, they're not sleeping well, they're not learning well, and there's no reason not to address it surgically. There's anesthetic risk is low, the surgical risk is low, and there's no impact on their craniofacial growth. So I don't really see a reason not to be aggressive with that, with operating on these children, unblocking their nose and improving their quality of life.
I think the problem often is the fact that they don't complain. They don't know any better. So really it's up to the parents. And it's at that point where they've got those green candles where it becomes socially unacceptable in daycare. I think it's sort of, that's the point. And I guess that's the problem often. We don't really have good, I mean, do you think we've got a good way of recording the data in children? Obviously the SNOT 22, they've tried to adapt, but in terms of quantifying the degree of difficulty, then makes it challenging to do any meaningful studies to show the benefit.
Yeah, it can be. I mean, there's other things such as you can look at, their sleep studies or their quality of sleep, things like that. But you're right, a child won't complain. They don't know any different. The parents can, like some of my parents will fill out the SNOT 22 score on behalf of the child, but really we don't know how accurate that is. And there's other like nose scores and things like that. But a lot of these scores that require the person themselves to score their symptoms, the parents are doing it for them. So it's difficult to quantify, but you can use things such as their quality of sleep, or if they've had a sleep study, if you're concerned, or you can, use other things such as the degree of rhinorrhea, how badly they're snoring, how many hours in a row they get for sleep. At the moment with COVID, I'm getting a lot of children coming because, as you mentioned, with daycare, the daycares are now sending them home time after time after time, or they're having multiple swabs to prove they don't have COVID. And whereas, last year they had the same symptoms, but they just weren't sent home. So parents are now coming to me more and more because their kids are not allowed to go to daycare. So, yeah.
And I'm interested in what you say about being more aggressive with the turbinates. Often we've been a bit nervous with children, particularly because in the past we've seen these big hemorrhages when we've been more aggressive with turbinate surgery historically. So we've all randomly given them a bit of diaphragmy along the side of the turbinate in those smaller children, or even the submucosal diaphragmy. Are you really, what age would you say, you should be being a bit bolder and being more aggressive, removing more of that mucosa and bone?
Whenever they need it. I mean, really, as I said, before the age of 6, but if you've got a 4-year-old with huge turbinates, allergies don't tend to develop that early. So it's rare that you'll get, a 2 or 3-year-old with big turbinates and allergic rhinitis. It tends to be more when they get towards 6, 7 or 8. But just in an adult, the risk of a bleed in a child is just the same. Obviously, it's more difficult to manage in a child that, you can't really pack them, etc. But if there's no reason not to address their turbinates. Obviously, I find the inferior turbinate artery deliberately. I actually go and find it, and I bipolar that. Mm-hmm. And in a child, I'm very careful what sort of material I put in afterwards. I try to avoid any packing, or if I do, I'll put something like maybe some Purigen or something absorbable at most, some fibrillar at most. But I try to avoid it. That way there's nothing they need to wash out or dissolve if that child's not going to be very compliant with their washes. But do it. If they've got big turbinates and they can't breathe, then the bleed rate is the same as an adult. In fact, it's probably lower than it is with adults. But I do encourage you to find that artery and cauterize it directly. Cauterize that tail.
Well, that's really helpful. You've just answered a question regarding postnasal care in these young children. As you say, You don't really be wanting to put packs in or anything potentially that could fall out or be removed at a later stage.
Yeah, I don't use any packs, or if anything, it's all absorbable. But the key thing is if you just cauterize or do something submucosal, what you're doing is damaging that mucosa long term and actually not going to help them long term. And there's no reason not to. It doesn't impact their facial growth.
Can I ask you about adenoids? We, as paediatric surgeons, are very fond of the cablator now. I mean, a lot of children, particularly for airway obstruction, will use an intracapsular tonsil technique with cablation. And that's changed our practice, and we use that with the adenoids too, rather than suction diathermy or curette. Have you got any thoughts on what's your favourite adenoid approach?
No, I've used both really. I don't ever curette now. It's always either coblation or suction diathermy with under direct vision. But the key thing is, I mean, I think coblation, adenoids aren't that painful. So whether it's coblation or suction diathermy, you know, they still do smell a little bit, but it's perhaps a bit less with the coblation because there's less charring. But really they only tend to get a smelly nose around for the 5 days. It lasts a day or two, and if they use a saline spray, it goes. The key thing is to address them with whichever technique you find is, yeah, to make sure they get addressed.
I mean, I would say that, you know, for years we've done curetting, and we've missed the entire posterior choanal clump. And I go back with revisions, and I just see that, you know, I can't imagine that sort of technique whereby you blindly pull out it without really addressing the real obstructive issues.
Yeah, absolutely. Yeah.
I don't know whether Kwame has any other questions.
There's been a flurry of questions coming through actually, and I'll run through some quick yes/no answers. The case with the cystic fibrosis, there was a question as to whether you would take a biopsy prior to surgery.
Well, it would have been very difficult to do a biopsy. She's 3, and it would have required an anesthetic. Plus, I had to actually open up the sinuses to get a biopsy. As you saw, the polyps were all kind of in that middle meatus and in the sinuses. So I biopsied at the time of surgery, but I'm not really sure what a biopsy would have helped me. She had cystic fibrosis.
I agree. Just rolling the question out to you.
Yes. Yes.
There was a question about which is a better decongestant to use in the pediatric world, kind of decongestants for children. Do you have any thoughts on that?
No, I've got some very strong thoughts on that. I don't use things like imidazolines or Drixine, Otrivin, I'm not sure what you call it there, but the xylometazoline and oxymetazoline for a few reasons. One, there is a known toxicity in children. It's rare, but it can happen. 2, there's actually, the way they work, it actually causes venous congestion, but doesn't have any impact on the arterial inflow. So when you decongest them, sure, it might look great because you've got that venous constriction, but you've still got the arterial inflow. And so if you use that, they actually bleed more. So what I tend to use in children is I'll topicalize with 1 in 2,000 adrenaline on neuropathies, and I'll inject them with a local anesthetic with an adrenaline in it. And it depends on their age as to which one I use and the strength of the adrenaline, but it's usually about 1 in 100,000 that I infiltrate with.
I've got a final question that was put through. If that's okay, Ashok. I know you're pressing us for time. I think this question was just looking at the bony work that you might do. Do you perform osteotomies in children? And I can only imagine the questioner is asking.
Kwame, yes, you're not very audible. Can you just come close to the microphone?
Can you hear me now?
Yes.
Yes, that's better. Thank you.
Sorry about that. The question was about osteotomies, whether you do osteotomies in children.
So is the question, do I do a medial maxillectomy? Is that what they mean by osteotomy?
My assumption was, I think when we were talking about septoplasties, if there's any bony work that needs correcting, would you do an osteotomy?
I would. If the bone is deviated and contributing to the nasal obstruction, I would. But it depends on the age of the child. So as you know, with children, most of their septum is cartilaginous. And so there's very little bone depending on their age. So yeah, I would if it was contributing to their obstruction, but I'd be mindful of those growth zones, the sphenodorsal and the sinospinal growth zones.
Thank you.